perioperative challenges. Because of time constraints, I will go through some algorithms and tables quickly. I will also share this presentation in the PACTA Academics WhatsApp group, so you can review the slides and references there. So I have no conflicts of interest to declare for this educational activity. And this is the roadmap for today's session. I will start with the major intraoperative challenges in thoracic anesthesia: one lung ventilation and failed lung isolation, hypoxic pulmonary vasoconstriction, airway emergencies with intraoperative hypoxemia, and hemodynamic and fluid management. And I will finish by discussing the key post-operative challenges, including post-operative pulmonary complications and post-operative pain management. So this is the same case as discussed by Dr. Imtiaz. So our anesthetic plan is general anesthesia with a left-sided double lumen tube to achieve reliable lung isolation for the right upper lobectomy. The DLT position will be confirmed with fiber optic bronchoscopy, and during one lung ventilation, we will use lung protective ventilation strategies. So the average length from the incisors to the vocal cord is 15 centimeter, and from the vocal cord to the tracheal carina is 12 centimeter. And the average distance from the tracheal carina to the origin of the right upper lobe bronchus is 2 centimeter in men and 1.5 centimeter in women. And the distance from the tracheal carina to the origin of the left upper and left lower lobe bronchi is approximately 5 centimeter in men and 4.5 centimeter in women. These anatomical distances apply to individuals with a height of approximately 170 centimeter, and the normal insertion depth for a left-sided double lumen tube measured at the teeth is approximately 28 to 29 centimeter in men and 26 to 27 centimeter in women. So generally, there are two broad indications for one lung ventilation: lung collapse for surgical exposure, for which bronchial blockers are the better choice, and protection of the healthy lung from contamination, for which double lumen tubes are the better choice. And in some patients, both indications may be present. So these images demonstrate the correct placement of a left-sided double lumen tube. Once the bronchial cuff passes the vocal cords, rotate the tube 90 degrees to the left, remove the stellate, and advance the tube until slight resistance is felt. A left-sided double lumen tube can be placed using a fiber optic guided railroading technique, in which the tube is railroaded over the bronchoscope and advanced into the left main bronchus under direct vision. Fiber optic bronchoscopy is the gold standard for confirming correct left-sided DLT placement. A well-positioned DLT shows a clear carina, an unobstructed right main bronchus, and the bronchial cuff seated just below the carina in the left main bronchus without herniation. The left image is the tracheal view showing herniation of the left-sided double lumen bronchial cuff, and the right image is showing left-sided double lumen tube positioned too distally within the left main bronchus. Right-sided double lumen tubes are reserved for situations where a left-sided double lumen tube cannot be used, such as left main bronchial tumors, injuries, stenosis, or after a left pneumonectomy. Their placement is technically more challenging because the ventilation slot must be precisely aligned with the right upper lobe bronchus, making fiber optic bronchoscopy mandatory. While auscultation is a useful initial check, it cannot reliably confirm correct DLT position. Fiber optic bronchoscopy is the gold standard, as it directly visualizes the tracheobronchial anatomy, confirms tube depth, and detects malposition before one lung ventilation. Bronchial blockers are indicated when a double lumen tube is difficult or undesirable. They are ideal for patients with difficult airways, those requiring post-operative ventilation, critically ill patients, and pediatric or small adults, while also providing effective lung isolation in selected thoracic and cardiac procedures. The arm wire guided bronchial blocker is one of the most widely used bronchial blockers. It features a nylon wire loop at its distal end that interfaces with a fiber optic bronchoscope, enabling precise endobronchial positioning under direct visualization. The spherical balloon provides effective bronchial occlusion. The accompanying multi-port airway adapter allows simultaneous ventilation, bronchoscopy, and bronchial blocker manipulation while maintaining a closed airway circuit. After endobronchial intubation, the multi-port airway adapter is attached to maintain continuous ventilation while allowing passage of both the bronchoscope and the blocker. The bronchoscope is passed through the nylon wire loop of the arm blocker, and the blocker is guided under direct vision into the target bronchus. Once the desired position is confirmed, the bronchoscope and wire loop are withdrawn, the balloon is inflated to achieve lung isolation, and the final position is confirmed with fiber optic bronchoscopy. The Cohen bronchial blocker differs from the arm blocker by using a rotating control wheel rather than a wire loop. Turning the proximal wheel deflects the distal tip, allowing precise steering into the target bronchus under fiber optic bronchoscopic guidance. The Rush EZ blocker is a bifurcated bronchial blocker designed to sit at the carina with one distal extension entering each main stem bronchus. Selective lung isolation is achieved by inflating the balloon on the operative side, while the opposite limb helps maintain stability and reduces the risk of blocker displacement. The Univen tube is a single lumen endobronchial tube with an integrated bronchial blocker housed within a dedicated internal channel, allowing lung isolation without exchanging the airway. The uniblocker uses the same blocker design but is passed through a standard single lumen endotracheal tube. It features a fixed hockey stick curved tip that can be rotated into the desired main stem bronchus, while a bronchoscopy port permits fiber optic guided positioning and continuous ventilation. The Ficon single lumen endotracheal endobronchial tube is a 36 centimeter long single lumen tube designed for both conventional ventilation and one lung ventilation. It has a short cuff and no Murphy eye, increasing the margin of safety during endobronchial placement. The tube can function as a standard endobronchial tube or be advanced into the desired main stem bronchus over a fiber optic bronchoscope when one lung ventilation is required. This slide compares the sizes of different tubes used for one lung ventilation. Be sure device selection should always be individualized based on patient anatomy, airway characteristics, and the surgical procedure. This table provides an age-based guide for selecting lung isolation devices in children. Bronchial blockers are the primary option in younger children, while double lumen tubes become feasible from around 8 years of age, depending on the child's airway size. This table compares the practical performance of left-sided double lumen tubes, right-sided double lumen tubes, and bronchial blockers. Left-sided double lumen tubes are the easiest to place because of their longer safety margin, have the lowest risk of intraoperative displacement, provide excellent access to the non-ventilated lung for suctioning and bronchoscopy, and offer excellent protection against contamination due to their hermetic seal. Right-sided double lumen tubes provide similar access and protection but are technically more difficult to position and are more prone to displacement, particularly after lateral positioning. Bronchial blockers are moderately easy to place but require fiber optic bronchoscopy for navigation, have a high risk of dislodgement, limited access to the operative lung, and only moderate protection against contamination if the balloon becomes displaced. This slide compares the airway morbidity profiles of double lumen tubes and bronchial blockers. DLTs are associated with the higher incidence of post-operative hoarseness and vocal cord injury due to their larger size, although serious tracheobronchial rupture is rare. However, once correctly positioned, they are highly stable, and malposition remains the main cause of intraoperative hypoxemia. In contrast, bronchial blockers cause less airway trauma because they are used through a standard single lumen tube, but they are more prone to displacement, particularly after patient positioning or in the short right main bronchus. Dr. Adnan has already discussed hypoxic pulmonary vasoconstriction in detail, so I will only briefly review it. HPV is one of the most important protective physiological mechanisms during one lung ventilation. It is a localized reflex in which hypoxia causes pulmonary arteriolar vasoconstriction, unlike the systemic circulation where hypoxia causes vasodilation. During thoracic surgery, when one lung is intentionally collapsed, HPV reduces the right to left shunt by diverting blood away from the non-ventilated lung to the ventilated lung. This improves ventilation perfusion matching and helps maintain arterial oxygenation during one lung ventilation. One lung ventilation is the ultimate physiological stress test in thoracic anesthesia. By intentionally collapsing the operative lung, we create an absolute right to left intrapulmonary shunt. The non-ventilated lung continues to receive approximately 20 to 30% of the cardiac output, but this blood bypasses gas exchange, producing venous admixture and a fall in PaO2. At first glance, it seems logical that if we stop ventilating one lung, we should create a 50% right to left shunt, since one of the two lungs is no longer participating in gas exchange. However, this is not what happens in clinical practice. During one lung ventilation, the actual shunt fraction is typically only 20 to 30%. And the three main important physiological mechanisms explain this difference. The first is surgical compression. Manipulation and compression of the collapsed lung mechanically reduce blood flow through that lung, limiting perfusion to non-ventilated alveoli. The second is gravitational shift. In the lateral decubitus position, gravity diverts more pulmonary blood flow toward the dependent ventilated lung, improving ventilation perfusion matching. And the third and the most important mechanism is HPV. HPV alone can reduce shunt flow by approximately 40 to 50%. The combined effects of surgical compression, gravitational redistribution, and HPV explain why the shunt fraction during one lung ventilation is usually 20 to 30% rather than 50%. HPV is essential for maintaining oxygenation during one lung ventilation by reducing intrapulmonary shunt. HPV is enhanced by mild acidosis, mild hypercapnia, catecholamines, almitrine, and adequate cardiac output. It is inhibited by volatile anesthetics, especially if MAC is more than 1, vasodilators, alkalosis, excessive pulmonary artery pressure, severe sepsis, and excessive vasopressor therapy. In thoracic anesthesia, HPV is supported by proper DLT positioning, lung protective ventilation, avoiding excessive airway pressures, maintaining cardiac output, and limiting volatile anesthetic concentrations. While high volatile anesthetic concentration, excessive vasodilation, hyperinflation of the dependent lung, and severe pulmonary hypertension impair HPV and worsen oxygenation. In patients requiring one lung ventilation, the first question is whether a difficult airway is anticipated. If the difficult airway is recognized preoperatively, the safest approach is awake flexible bronchoscopy or awake video laryngoscopy to secure the airway while maintaining spontaneous ventilation. If the difficult airway is unexpected, the priority is to oxygenate the patient first, followed by airway management using video laryngoscopy or flexible bronchoscopy. Regardless of the pathway, the goal is to secure the airway with a single lumen endotracheal tube first. Once the airway is secured, correct tube placement should be confirmed with bronchoscopy. For lung isolation, the bronchial blocker is the first choice in patients with a difficult airway because it avoids exchanging the airway and minimizing the risk of losing it. At this point, two clinical scenarios should be considered if the operation requires rapid lung collapse, repeated suctioning of the operative lung, or CPAP to the non-dependent lung. A double lumen tube may be advantageous, and an exchange can be performed over an airway exchange catheter once the airway is secured. On the other hand, if post-operative mechanical ventilation is anticipated, the preferred strategy is to leave the single lumen tube in place with the bronchial blocker, avoiding an unnecessary tube exchange. The key message is simple. Secure the airway first, isolate the lung second. In the difficult airway, a single lumen tube with a bronchial blocker is the safest initial strategy, while conversion to a double lumen tube should be reserved for selected cases where its specific advantages outweigh the risks of airway exchange. DLT displacement is the most common airway complication during one lung ventilation, occurring in about 20 to 40% of the patients after lateral positioning. It commonly occurs during patient positioning, neck movement, surgical traction, or inadequate tube fixation. Management of DLT displacement follows a simple stepwise approach. First, increase FiO to 100% to treat hypoxemia. Next, temporarily return to two-lung ventilation to stabilize the patient. Then use fiber optic bronchoscopy to confirm the tube position. Reposition the DLT as required and repeat bronchoscopic confirmation to ensure correct placement. And finally, reassess oxygenation and ventilation before resuming one lung ventilation. Bronchial blocker displacement is commonly caused by surgical manipulation, lung collapse, patient repositioning, cuffing, or inadequate balloon inflation. It should be suspected if there is a loss of lung isolation, re-expansion of the operative lung, hypoxemia, or increased airway pressures. Fiber optic bronchoscopy is essential to identify proximal or distal displacement or balloon herniation into the trachea. Management is straightforward. Perform immediate bronchoscopy, reposition the blocker under direct vision. Bronchial injury or rupture is a rare but potentially fatal complication of lung isolation. Risk factors include female sex, older age, COPD, steroid therapy, tracheobronchomalacia, oversized DLTs, excessive cough inflation, and difficult or forceful intubation. Suspect it if there is a sudden air leak, loss of tidal volume, pneumomediastinum, or subcutaneous emphysema. Fiber optic bronchoscopy confirms the diagnosis and defines the location and extent of the injury. Management includes 100% oxygen, maintaining ventilation with low airway pressures, immediate bronchoscopic assessment, early thoracic surgical consultation, and lung protective ventilation until definitive treatment. Airway obstruction during one lung ventilation may be caused by a King double lumen tube or bronchial blocker, mucus plug, blood clot, herniated cuff, or surgical compression of the bronchus. And it should be suspected if there is a sudden rise in airway pressure, reduced tidal volume, hypercapnia, desaturation, or absent breath sounds. Fiber optic bronchoscopy helps identify the cause, such as the mucus plug, blood clots, distal obstruction, or tube kinking. And the management includes checking the breathing circuit and tube reposition, performing bronchoscopy with suction, removing any blood clot if present, and replacing the tube if necessary. Swelling of the airway with blood is a life-threatening complication that may occur during pulmonary resection, trauma, lung abscess, bronchiectasis, or necrotizing pneumonia. It should be suspected if there is blood in the double lumen tube, sudden desaturation, increased airway pressure, or blood seen in the bronchoscopy. The immediate priority is to protect the healthy lung. Management includes aggressive suctioning, confirming DLT position, are using a bronchial blocker to isolate the bleeding lung, maintaining oxygenation with two-lung ventilation if required, and informing the thoracic surgeon immediately in cases of massive bleeding. If the patient develops a sudden drop in oxygen saturation below 90% during one lung ventilation, act immediately. First, increase FI to 100%. If oxygen saturation does not rapidly improve above 90%, stop one lung ventilation and immediately resume two lung ventilation. Do not spend time troubleshooting or performing diagnostics until the patient is physiologically stable. Once the patient is stabilized on two lung ventilation, systematically look for reversible causes. First, use fiber optic bronchoscopy to verify the position of the BLT or bronchial blocker, as malposition is the most common cause. Next, clear the airway by sectioning any mucus, blood, or secretions from the ventilated lung. And finally, optimize systemic output by correcting hypovolemia, improving cardiac output, and addressing any hemodynamic instability. If hypoxemia persists despite correcting reversible causes, escalate treatment step by step. First, recruit the ventilated lung and optimize PEEP. If oxygenation remains inadequate, apply oxygen insufflation or CPAP to the non-ventilated lung after informing the surgeon. Next, consider selective lobar ventilation or partial lung inflation. If hypoxemia is still severe, the surgeon may temporarily reduce blood flow to the operative lung. As a last medical option, nebulized pulmonary vasodilators may improve oxygenation, and in the refractory life-threatening hypoxemia, ECMO should be considered. Thoracic surgery can cause cardiovascular instability through two main mechanisms. First is the preload falls first preload falls because in the lateral position, positive pressure ventilation and with high PEEP and mediastinal shift reduces venous return, leading to hypotension. And the second, afterload increases. The right ventricle is particularly vulnerable during one lung ventilation. One lung ventilation creates a right to left shunt, and hypoxic pulmonary vasoconstriction increases pulmonary vascular resistance, raising the RV afterload. The thin-walled RV ventricle may dilate, causing the interventricular septum to shift toward the left ventricle. This reduces left ventricular filling and cardiac output, leading to hypotension. TE is the gold standard for diagnosing intraoperative RV dysfunction. And the management focuses on avoiding fluid overload and reducing pulmonary vascular resistance with selective pulmonary vasodilators, such as inhaled nitric oxide or mildenone. And this has been discussed by Dr. Imtiaz in detail. Let's come to the post-operative challenges. So, post-operative pulmonary complications are a major cause of morbidity after thoracic surgery. They can be grouped into four categories: airway complications, parenchymal complications, pleural and surgical complications, and ventilatory complications. General anesthesia and post-operative medications significantly reduce lung volumes and the ventilatory pattern. Total lung capacity decreases after upper abdominal and thoracic surgery, but not after extremity surgery. Vital capacity decreases by 25 to 50% within 1 to 2 days after surgery and generally returns to baseline within 1 to 2 weeks. Residual volume increases by 13%, while expiratory reserve volume decreases by 60% after thoracic surgery. Tidal volume decreases by 20% within the first 24 hours and gradually return to normal over approximately 2 weeks. Pulmonary compliance decreases by 33%, accompanied by a similar reduction in FRC due to small airway closure. And patients undergoing lung resection are commonly smokers with COPD, and the risk of post-operative pulmonary complications increases with both the extent of lung resection, lobectomy versus pneumonectomy, and the severity of pre-existing lung disease. Post-operative pulmonary complications are often driven by a vicious pain respiration cycle. Surgical pain causes patients to take shallow breaths and avoid coughing. This leads to splinting, secretion retention, and reduced FRC, resulting in atelectasis and hypoxemia. Atelectasis is the most common post-operative pulmonary complication and often progresses to pneumonia and respiratory failure. The key message is breaking this cycle with effective multimodal anesthesia is one of the best ways to prevent post-operative pulmonary complications. This has been discussed in detail by Dr. Imtiaz, and this also, and let me come to the key messages. Okay. To conclude, these are the 8 key messages from today's session. First, understand the physiology. Thoracic anesthesia intentionally creates a major VQ mismatch, and preserving HPV is essential for oxygenation. Second, secure the airway first by choosing the appropriate lung isolation device and always confirm its position with bronchoscopy. Third, manage hypoxemia systematically, oxygenate first, then identify and correct reversible causes. Fourth, pro- protect both the lungs and the heart by maintaining stable hemodynamics and recognizing right ventricular dysfunction early. Fifth, be conservative with fluids and use goal-directed therapy to avoid fluid overload. Sixth, focus on preventing post-operative pulmonary complications through lung protective ventilation, pulmonary hygiene, and early mobilization. Seventh, remember that pain control is the respiratory therapy. Use multimodal analgesia with regional techniques whenever possible while minimizing opioids. Finally, teamwork saves life. Close communication between the anesthesiologists, surgeons, intensivists, nurses, and respiratory therapists is the key to achieving the best perioperative outcomes.